Our next speaker I am very happy to introduce is Dr. Michelle Sholzberg. Michelle is an associate professor of medicine and the departmental division director of hematology at the University of Toronto, my alma mater. If that's not enough responsibility, she is also the medical director of the coagulation lab at St. Mike's Hospital, the director of hematology oncology clinical research group, and co-director of the Hematology Immunology Translational Research Team of the Li Ka-shing Knowledge Institute. Michelle received her medical degree and internal medicine training at McGill, followed by postgraduate training in hematology and hemostasis in Toronto, further complemented by an MSc in clinical epidemiology and healthcare research. She combines her many skills to uniquely address important areas in hemostasis and health equity, and that's what we're hearing about today. Thank you very much for joining us.
Thank you so much for having me. It's such a privilege, and you've all made me realize how little I know about VWF. So this is going to be a bit of a shift of focus. I'm here to speak about the patient's experience with VWD with a focus on women, but as an important disclaimer, I don't have VWD. These are some relevant financial disclosures, but probably most importantly, I have a ton of intellectual bias as I've dedicated my entire career to the stuff that I'm presenting today, so I think it's really important. I hope you do too. Throughout this talk, I'm going to use the terms women and mothers to highlight the experiences and care gaps for women, and sometimes the term females in reference to the biological capacity to menstruate, become pregnant, give birth, and lactate. Of course, these terms are exclusionary, and I ask you to please recognize that these experiences apply to people with the anatomy that allow for all of these things. So I'm going to go through the impact of bleeding on women's health with a focus on VWD, describe the interconnectedness of iron deficiency and bleeding, compare and contrast the evidence versus myths surrounding tranexamic acid use, and then go through some constructive new directions. So these are inextricably linked themes for women of reproductive age that, of course, is highlighted for those with bleeding disorders such as VWD, and that's iron deficiency anemia, heavy menstrual bleeding, and postpartum hemorrhage. Professor von Willebrand was the first to describe what we now call von Willebrand disease. I'm not going to go through this in detail. We've discussed it all day, but as we all know, it's the most common bleeding disorder. VWF is this hemostatic bomb that is made and stored in platelets and endothelial cells, and excessive vaginal bleeding is the most common symptom. It's very possible that some of the things I'm going to be discussing today may make you feel uncomfortable. Some of the images that you may see today may make you feel uncomfortable, but I think it's okay for us to feel that discomfort sometimes. So what is the impact of VWD on overall health and well-being? So gynecologic and obstetrical complications in VWD are very common. You'll see in this slide there is a pad soiled with blood. This is probably an image that many of you have never really seen before. Some of you have, but even still, if you've seen it personally, it's not an image that you're used to seeing on a slide. And when I showed this slide to my own mother a few years ago, she said, "Misha, you can't show this." And I said, why? Why? Isn't it a problem that we feel uncomfortable? And so we're going to get desensitized to the image because this is something that half of the world experiences. So 95% of women with VWD, essentially all, have heavy menstrual bleeding, and bleeding complications around pregnancy and childbirth are exceedingly common. What are the lived experiences and barriers to care that women with bleeding disorders experience? And this work was led by Dr. Sumeda Arya, where she conducted a series of qualitative interviews with women with bleeding disorders. And this is one of the first publications on the topic that we published in 2020, that really wasn't that long ago, to describe the lived experiences of women with bleeding disorders. And what were the themes that emerged? The impact on identity in daily life, the uncertainties surrounding the diagnosis, conceptualization of experience through family bleeding, and intensity of bleeding symptoms. And I quote, "When I started my period, I wasn't sure what was normal or not." Dr. Heather Vandermeulen conducted a similar qualitative study because we asked ourselves in clinic, can women with inherited bleeding disorders effectively identify excessive postpartum vaginal blood loss? Because we wondered, they've experienced heavy vaginal bleeding their entire reproductive lives. Are they adept at picking up abnormal postpartum bleeding? And here are the themes that emerged: missing dialogue surrounding vaginal blood loss, lack of effective communication around postpartum bleeding with healthcare providers, normalization of bleeding and a skewed frame of reference regarding vaginal bleeding, as well as inadequate access to care with geographical and socioeconomic barriers, lack of preparation, and lack of communication amongst physicians. As far as I'm concerned, it's completely normal to have heavy bleeding after delivery. I didn't have to call an ambulance. I wasn't in and out of consciousness. Those are my opinions of true hemorrhages, but it wasn't like that with my delivery. So these themes emerged in our work of normalization and desensitization, and essentially all women with VWD experience heavy menstrual bleeding, but if you were to ask them, 70% of them report normal menstrual bleeding, despite having measurements in keeping with heavy menstrual bleeding, and that is because people gauge the normalcy, or gauge the normalcy of our experiences, all experiences, including those with vaginal blood loss, by referencing our own personal experiences and potentially our family experiences. And if you're referencing an individual within your family who also has abnormal bleeding, heavy vaginal bleeding becomes further normalized and generations become desensitized. Also, the stigma surrounding menstruation obstructs conversations about vaginal bleeding with non-relatives. So Dr. Arya then conducted a subsequent study specifically focused on barriers to care, and I quote, "They don't really take my bleed seriously." And here are the themes: healthcare provider dismissal of symptoms, limited access to care, need for self-awareness and advocacy, lack of healthcare provider awareness of inherited bleeding disorders. I find out that no matter how many times I have to go to the emergency department, that a pre-existing narrative is usually there. But I've learned how to better advocate for myself. You have to be prepared to advocate because you can't rely on them to know what you're talking about. So despite VWD being the most prevalent inherited bleeding disorder, diagnostic delay and misdiagnoses make timely identification and management extremely challenging. In fact, the average time from first symptom onset to clinical recognition is 16 years. And these delays on average are 6 years longer for women than men. And even if a patient identifies with abnormal bleeding and presents to medical attention, they frequently experience dismissal, leading to serial misrecognition and then healthcare trauma. Now, we're breaching some core principles of bleeding disorder management with VWD and other disorders that affect women. So these are the management principles: treat first, investigate later. But this is if you believe the patient and if they have access to diagnostic testing and treatment. And for any patient with VWD, they have to earn prophylactic factor concentrate or other forms of prophylaxis in a way that a patient with hemophilia simply does not. And despite the high prevalence of VWD and the near universality of heavy menstrual bleeding, the role of VWF replacement for VWD for prophylaxis of heavy menstrual bleeding is as of yet undetermined. The cycle of sexism in the management of bleeding disorders has been described by my wonderful colleagues, and they indicate that the lack of knowledge and comfort that patients and healthcare providers have in discussing vaginal blood loss leads to only 4 out of 10 women with heavy menstrual bleeding seeking care. And despite VWD being 10 times more common than the hemophilias combined, it has significantly fewer resources devoted to it. But this impact extends far beyond patients with bleeding disorders. And so if I pull back and just speak about heavy menstrual bleeding amongst all people, what are the facts? The prevalence ranges between 15 and 61% of women, but a more recent accurate estimate is 51% of all women on this earth experience heavy menstrual bleeding. But defining it is really challenging. It's defined as menstrual blood loss of greater than or equal to 80 milliliters of blood per cycle. I have no idea what that means as a woman of reproductive age standing right up here today. But I know that we can't ask our patients, do you have heavy menstrual bleeding? Because we're inviting them to lead with their bias. Because if she's bled heavily her entire life, she's going to say, no, it's normal. So how do we quantify heavy menstrual bleeding? There are many methods that are available for use, ranging from the alkaline hemotin method, which really is not a favored approach, to the pictorial blood assessment chart that quantifies, giving a score to how saturated a pad or tampon is. A score of greater than or equal to 100 over the person's entire menstrual cycle is equivalent to losing more than 80 milliliters of blood. Where we came to getting that definition of greater than 80 milliliters of blood being in keeping with heavy menstrual bleeding is that is the threshold beyond which iron deficiency develops. There are menstrual cups, there are bleeding assessment tools. Now, bleeding history is the most important test of hemostasis, and these bleeding assessment tools provide some guidance to talk about vaginal blood loss, but not a lot. The more medical or surgical intervention that a person requires to control any bleeding in any category, they get more points, but it doesn't really tell you how to ask the questions. Dr. Paula James and her team recently validated the PBAC using modern menstrual products. The original PBAC was published in 1990 using menstrual products that were available in the 1980s. Since then, menstrual products have evolved substantially to hold more blood, to keep us dry, to be less obstructive in our daily lives. And so just recently, published in 2021, the PBAC was revalidated using modern menstrual products, so it was likely an underestimate for multiple decades. Furthermore, colleagues at the University of Oregon recently published on menstrual products being fundamentally flawed as a surrogate measure for heavy menstrual bleeding. And until recently, these products were historically tested using saline, and we can acknowledge that the viscosity of saline is very different than the viscosity of blood. And what they found is that depending on the product that you're using, that the amount of blood that could be held in a different product varied significantly, ranging from 2 milliliters to 61 milliliters. And saturating 2 heavy pads is equivalent to 100 milliliters of blood loss, or 3 heavy tampons is 90 milliliters of blood loss. So right there, you've met the diagnosis for heavy menstrual bleeding. So if we're relying solely on the frequency of blood product changing and not asking about what products are being used, we're missing a significant amount of women with heavy menstrual bleeding. The VWD guidelines suggest this new definition that does consider the amount of products that you're changing, how long your period is lasting, whether or not you're passing clots, waking up in the middle of the night, and this aligns with the ACOG definition, but the type of products used, you'll note, is missing from this definition. So postpartum hemorrhage, what are the facts? Every year, 14 million women experience a postpartum hemorrhage, accounting for 70,000 maternal deaths. It is the #1 cause of maternal death globally. Black women are 3 times more likely to die of postpartum hemorrhage than white women in the United States of America. And when women survive, they often need urgent surgical interventions to control the bleeding, and they may be left with lifelong reproductive disability. So how do we define postpartum hemorrhage? Within the first 24 hours of birth, that's primary PPH, greater than 500 milliliters. For a vaginal delivery, greater than a liter. For a cesarean section, obviously really hard to quantify. Most of the blood ends up on the floor. This definition was proposed by a WHO working group in 1989 and uses the same threshold for all women irrespective of antecedent maternal anemia, and that is despite, in 1989, recognition that an alternative definition was required. Secondary postpartum hemorrhage is bleeding that persists up to 6 weeks. It's a total black box. I truly have no relevant estimates to provide. We know that women with bleeding disorders, including VWD, are at disproportionate risk of postpartum hemorrhage. It's at least 4 to 5 times more common, with at least a 10 times greater risk of death. So when we asked women about their experiences with heavy vaginal bleeding, this here is our table 1 describing the women that we evaluated, a really diverse group that was purposeful, a very educated group, and you'll notice that they had heavy menstrual bleeding or heavy vaginal bleeding for years and years and years. So when we asked, walk me through your experience with excessive vaginal blood loss and when you first noticed your symptoms weren't normal. I didn't understand how these period products are for a full 8 hours. I can't even sleep for a full 8 hours without having to change. Has knowing there's a name to it, heavy vaginal bleeding, and treatment changed the way you live? I'm now able to be a functioning person. I thought I was supposed to be incapacitated for days. How can we do better? This is a really important quote. I was a bedside nurse in a hospital for approximately 10 years. We asked people about their bowel movements daily. We asked them about their voiding daily. We asked people how many cups of water they drink in the hospital. Why can't we ask them about their menstruation that day? How can we do better? The one thing so important as a Black woman is being believed. There is so much power in just believing someone, and that's the title of the paper. So Dr. Fartoun Siad asked trainees at the University of Toronto, 73 medical trainees across a variety of different specialties, because we wanted to know if healthcare provider trainees were adept at asking about vaginal blood loss. And here's what we found, and this was the first study that we could find on the topic. So green means agree, red means disagree. So people are generally comfortable diagnosing excessive vaginal blood loss, generally pretty comfortable diagnosing a primary postpartum hemorrhage, less comfortable diagnosing a secondary postpartum hemorrhage. When we asked people if they'd heard about the PBAC, 21% had heard of it, 56% had heard of BATS, nobody had heard about the alkaline hematin method, which is fine. Menstrual cups, half the people had heard about a menstrual cup, but when we asked them if they'd used it in clinical practice, nobody had used it. So while we found that a broad range of medical learners described themselves as largely feeling comfortable with their skills in assessing vaginal bleeding and being aware of some tools that are available to facilitate the diagnosis, very few had used them in clinical practice. And we think that this shows excessive confidence in its diagnosis amongst medical learners, and we don't think that it's the fault of the learners. We think that this signals a structural problem. So this is going to take me briefly to tranexamic acid, and I'm going to briefly show the results of the woman trial, which, as I'm sure you all know, was a very large randomized controlled trial involving 20,000 plus women around the world with postpartum hemorrhage. Most of the women were recruited in Africa and Asia. This was a clinical trial of tranexamic acid versus placebo for postpartum hemorrhage. Now, this was a negative study, in fact, pertaining to its primary outcome, which was mortality or hysterectomy. However, a key secondary outcome, which was hemorrhagic death, is positive pertaining to that important outcome. And this, in fact, then changed standard care. And if you give tranexamic acid early, it was particularly effective with no increase in thrombotic events. So this brings us back to these inextricably linked themes, and I'll show you how. This was a qualitative study that came out of the woman trial where they collected narratives from half of the obstetricians who cared for the women who died in the trial. There were 483 maternal deaths in the woman trial, 375 in Africa, 105 in Asia, and of all of the patients recruited in the UK, none of them died. And I quote, "She died because we could not replace all that she had lost. She died because of severe blood loss and pre-existing anemia and lack of more blood for transfusion. The main cause of death was anemia, which became complicated by heart failure, from which she never recovered." So a core driver to postpartum hemorrhage-related death is uncorrected maternal anemia. And so tranexamic acid is now considered standard care for the management of postpartum hemorrhage by multiple organizations internationally. Tranexamic acid is also exceedingly helpful in the management of heavy menstrual bleeding. It's also considered part of standard care. It's incredibly safe. But there are barriers and myths. So I'm going to just show you here the label in Canada. The labels are very similar for the EMA and the FDA. And I quote, "The risk for thromboembolic events may be increased in patients using hormonal contraceptives." And it says active thromboembolic disease and history of thromboembolism is considered a contraindication for tranexamic acid use. So does tranexamic acid associate with risk of thrombosis? So this is a large systematic review and meta-analysis of non-surgical patients, no increased risk of venous or arterial thrombotic events. In surgical patients, same story. 2 million Danish women were followed for 13.8 million person years where tranexamic acid was prescribed for at least 5 days of their menstrual blood loss. The number needed to harm for one venous thromboembolic event was essentially 1 in 80,000. There was no relevant number needed to harm for arterial events. So there are gaps that remain, a big knowledge to action gap for many therapies for the management of heavy menstrual bleeding. And now this takes me to iron deficiency and anemia, and this one I'll go through very quickly. So the challenge of iron debt for women of reproductive age is very real. A woman loses with a normal menstrual period 10 to 20 milligrams of iron per menstrual cycle, and when her iron losses chronically outpace her intake, iron deficiency develops. The recommended iron intake for a woman of reproductive age is 18 milligrams per day. In the United States, the average intake is about 12 to 13 milligrams, and that's just with a normal period. So you see that with a normal period, if you're not nourishing yourself effectively, it's very easy to become iron deficient. Now, in pregnancy, it takes iron to make the enhanced maternal blood volume, to make the baby, to make the placenta, to account for lochial losses, and it takes a gram of iron to make a baby, and I know that a gram doesn't sound like a lot, but that's equivalent to 177 large steaks. So does anemia matter, right? We've become so desensitized as clinicians. Does iron deficiency matter? Here to say that it matters. So this is data from ICS using a large administrative data set in Ontario of nearly 1 million women, a retrospective cohort study that looked to determine if there was an association between severe maternal morbidity, mortality, or blood transfusion with maternal hemoglobin that was evaluated early in pregnancy over the course of the woman's entire pregnancy. And what was found is that a low maternal hemoglobin in early pregnancy was associated with a higher risk of severe maternal morbidity, mortality, or transfusion of blood. And that's in the province of Ontario. Now, really importantly, this risk of adverse maternal outcomes was higher even with a hemoglobin between 110 and 124, which is currently above the threshold to define anemia or the recommended threshold to initiate iron therapy in pregnancy. But does non-anemic iron deficiency matter? It does. It matters too. It's actually independently associated with risk of death. It's associated with decreased exercise tolerance, pica, the urge to eat inedible things, which I think should make us reframe the concept of cravings that women have when they're pregnant. Decreased mood, it's associated with mood disorders, including postpartum depression, and a decreased IQ, because it negatively impacts memory, attention, and speed. Because iron isn't just important for red blood cells. Iron is important for many, many, many different processes in our body, including the synthesis of serotonin and dopamine. Now, all of this is associated with a decreased health-related quality of life, and iron supplementation does improve many of these outcomes. But iron deficiency is cyclical, it is compounding, it is intergenerational. And that is because people who are of lower socioeconomic status, those who are marginalized and racialized, are at greater risk of iron deficiency because iron-rich foods are expensive and because these individuals who are more vulnerable have diminished access to health care, even in our universal health services system in Canada. So iron deficiency affects those that are most vulnerable, but the mother confers her iron status to the fetus. And babies that are born to mothers who are anemic are at greater risk of autism spectrum disorder, ADHD, and intellectual disability in early childhood. So iron deficiency affects the most vulnerable, and it is vulnerable making. A third of the world has iron deficiency anemia. In some parts of the world, it's as close to 80% of the population that has iron deficiency anemia. In Ontario, 40% of women of reproductive age who aren't pregnant have iron deficiency, and 13% have iron deficiency anemia. And of those, the majority have a normal MCV. In pregnant patients in Ontario, 50% of those early in pregnancy have iron deficiency, but 40% of those were never even screened. At St. Michael's Hospital, when you deliver, 77% of those who deliver have iron deficiency. So this is the original pandemic, but how could it be a pandemic? It's correctable. It's one of the few things in medicine that we can treat in a fairly straightforward way. That's because it's structurally sanctioned by flawed ferritin and hemoglobin reference intervals. And so the thresholds to define anemia by the WHO were first adopted in 1968 on the basis of 4 published references and 1 set of unpublished observations. And Dr. Blitt Hansen is presenting her poster today that shows that iron status has generally not been considered in all the studies that she conducted a systematic review on when considering what appropriate anemia thresholds are. So iron deficiency is an intersectional storm. It is the most common micronutrient deficiency globally. It affects 2 billion people. Iron deficiency anemia affects 2 billion people annually. Iron deficiency is the #1 cause of anemia. It disproportionately affects women and children. It's the leading cause of years lived with disability in women worldwide, and it is correctable. So I'm going to very quickly end off that I'm very grateful. This is not meant to be a nihilistic talk. There are lots of great things going on. So I'm grateful for the move away from these frankly unfeasible vaginal bleeding assessments and this shift towards more relatable, modern, qualitative assessments that consider the impact of quality of life in women who experience heavy vaginal bleeding. The WHO has set iron deficiency anemia as a key global health priority for 2025, and there are a ton of amazing efforts in knowledge translation focused on iron deficiency and women's health in general. Dr. Heather Vandermeulen found that access to multidisciplinary care for women with bleeding disorders is found to be protective. And so at St. Michael's Hospital, we have a multidisciplinary clinic for women with bleeding disorders, and we provide all of our patients with a multidisciplinary care plan, and they also get a copy of the care plan that says how they should be managed, how the baby should be managed, how to provide them with neuraxial anesthesia if appropriate, and this is aligned with the VWD guidelines. It's now acknowledged by ASH that ferritin reference ranges need to be changed. And last year, there was a talk entitled The Education Program, Sex, Lies, and Iron Deficiency, a call to change ferritin reference ranges. In Ontario and in multiple other provinces, and the change is going to be coming soon in BC. I thought it was already done, but it's coming soon. There are a few hiccups. Where we've made this shift to the lower limit of normal for ferritin to a clinical decision limit of 30 for adult patients and 20 for pediatric patients, which we've entitled Raise the Bar. It took us 4.5 years to raise the bar. So these inextricably linked themes for women of reproductive age are unfortunately predicated on health inequity, structural discrimination, normalization and desensitization of heavy vaginal bleeding, as well as normalization and desensitization to anemia and iron deficiency in healthcare. And I'm going to read this out to you all, and these are all evidence-based statements. The more you bleed, the more iron deficient and anemic you become. The more anemic you are, the more you bleed. The more you bleed, the more likely you are to miss school and work. The more vulnerable you are, the less likely you are to receive care and to achieve success. The more unaddressed your heavy menstrual bleeding is, the more anemic you are in pregnancy, the more likely you are to have a postpartum hemorrhage and die. So it's time to reframe our concept of normal. Having heavy vaginal bleeding is not normal. Our patients often can't distinguish between normal and abnormal vaginal bleeding. Medical learners are inappropriately confident in diagnosing heavy vaginal bleeding. I don't think the learners at U of T are different from the learners at UBC or elsewhere. Having iron deficiency isn't normal. Having iron deficiency anemia isn't normal. Both should immediately prompt open dialogue about vaginal bleeding. Current structures permissively lead to normalization, desensitization, dismissal, and blame placement of heavy vaginal bleeding, iron deficiency, and iron deficiency anemia, and these impacts are intergenerational. Multidisciplinary care is best-in-class care for women with bleeding disorders, including those with VWD. Knowledge translation and exchange is critical, which includes guideline harmonization to provide one clear message. And I believe that this is the responsibility of the hematologist. There are a million people that I need to acknowledge, but first and foremost, my patients, because I wouldn't do any of this without being inspired by them. But I wanted to specifically thank Drs. Tang and Blitt Hansen, who are both here today, for their amazing work. Thank you.
Hi, absolutely fantastic talk. Thank you for kind of decreasing the stigma regarding this topic. I was really curious. It seems like so frequently with women who experience heavy bleeding that the treatment is just birth control, hormonal birth control, and it kind of stops there. When really it seems like in some cases the root of the problem is a bleeding disorder, von Willebrand disease. What's kind of, I guess, how do you go about diagnosing that, and then how does the treatment differ once someone is diagnosed with a bleeding disorder?
Thank you. Great question. So hormonal therapy is first-line therapy for the management of heavy vaginal bleeding in women with and without bleeding disorders, and is often exceedingly effective. In fact, progesterone-eluting IUDs have substantially decreased hysterectomy rates across all women of reproductive age. So I think that providing the option to consider hormonal therapy for all patients, including those with VWD, is really important. Earlier we were learning about the effects of estrogen in mice. I find it fascinating that the results were the opposite of what I thought they were going to be, but thrillingly, we see that when we give patients combined contraceptive pills that include estrogen, we see their VWF levels go up, and it's awesome, right? Because most people have type 1 VWD, so it's a wonderful treatment in a variety of ways, and it's satisfying because you feel that it's treating the anatomical issue directly, but we also feel like it's a partial treatment for their bleeding disorder. I think that tranexamic acid is probably one of the most underutilized drugs, at least in my area of expertise. There's so many myths that obstruct its use, including the myth that it should not be prescribed concomitantly with estrogen-containing therapies. There's no evidence to support that. We've conducted a systematic review. There's absolutely no evidence to support that claim whatsoever. We prescribed it concomitantly all the time in women with bleeding disorders and without bleeding disorders. But the truth is there's huge variation. There's data that Grace and I recently became aware of from Ontario Health that showed that if you look at different regions in Ontario, and I'm not speaking about women with bleeding disorders, just all women, that there's huge variation in hysterectomy rates depending on where people live in Ontario. So there's a critical need to harmonize the approach to vaginal blood loss, to debunk the treatments and treatment options for our patients. And all of that, I think, can be addressed with effective knowledge translation that critically needs to include patient partnership.
Thank you.
Hi, Michelle. Hey.
Yeah.
We have great treatments to correct iron deficiency, things like IV iron, which works really well, but to access especially some of the newer products, you have to actually be anemic, which just seems counterintuitive. Why don't we correct this? when the ferritin is already drifting? And how do we overcome those sort of system guardrails that have been put in place, I think incorrectly, but how do we work towards overcoming that and have the funders who pay for these really effective, simple therapies to understand that we need to be a step further than waiting for anemia?
Oh, thanks so much, Mark. I totally agree with you. I think that when we get to anemia, we've already hit end organ damage, right? Like we should be addressing the deficiency earlier. And not to be heme-centric, but iron is important for so many different things in our body. It's really hard, but I actually think that it starts with prioritization of research in the area. There remain huge knowledge gaps, really critical knowledge gaps. Iron deficiency, non-anemic iron deficiency research and iron deficiency anemia research has been grossly underfunded for decades. I think things are starting to change, but I think that a lot of that work needs to be divorced from the companies that make intravenous iron. I think that having that arm's length approach is really, really important. But we need to generate more data in a lot of different spaces, including data surrounding iron deficiency screening and showing that treating it when you screen at the population level, that people experience improved outcomes. For people like you and I who treat this every single day, it seems like almost insane. Like, are we actually questioning whether or not this treatment is effective? Like, I'm so with you, but I actually think that we need to generate large level data, taking a page out of the book of all the people who do cardiovascular research. That's the level of data that we need. Yeah. The other problem, the other issue is that, and this has been, I think, a huge negative aspect pertaining to iron deficiency research, is that oral iron supplements are categorized as supplements, not as treatments. And so the level of evidence that is required in that category and to get those drugs available by the various regulators, the bar is so low, which is a huge problem.
We have several questions online, and I think we only have time for one. Since von Willebrand disease patients don't get the same access to care as hemophilia patients, how can we, as care providers, improve prophylactic treatment for von Willebrand disease women?
Great question.
It's a huge question.
It's a huge question. Again, I think it comes, we need to generate data that prophylactic VWF replacement or other forms of prophylaxis, there's now a lot of really exciting research being done in the area. So I think that the landscape is changing. We need to generate data, and we need to show that it improves outcomes. So that bullet that I mentioned, that the fact that we don't have clear data to demonstrate that VWF replacement is an effective prophylactic treatment for heavy menstrual bleeding in people with VWD, we can describe it as appalling.
And overcome the stigma.
Right, exactly.
Yes.
But we just need to be like, it's okay. Like, it's not that big of a deal. Exactly. And we just need to invest in research so that the guidelines can be generated and be crystal clear. That's it.
Thank you very much for a great